Good morning. So before I start, I had a conversation with Joel Wallman, this Joel, and he asked me, was my tie either a clip-on or did I tie it? For everyone, I actually did this myself this morning. If you want some tutorials, I can show you after this. Let me start here. So my work primarily focuses on gun violence and community violence intervention, specifically evaluating CVI programs in Washington, D.C., as well as hospital violence intervention programs. And I want to start this conversation here in terms of the life differential and the life expectancy between Black and white men who live in the District of Columbia. Here is a chart of the life expectancy in different areas of the district. And as you can see in Georgetown, which I'm sure many of you know, life expectancy is 94 years. We know that Georgetown is primarily a white, affluent neighborhood in Washington, D.C. But if we travel over to Trinidad, you see the life expectancy is 67. That neighborhood is predominantly poor and Black. Another way of framing life expectancy in D.C. in terms of the differentials between Black and white neighborhoods, here in Woodley Park, which is where the National Zoo is located, that neighborhood is primarily middle to upper middle class and white. And St. Elizabeth's, which is located east of the river in Congress Heights, is predominantly poor and Black. And the differential, as you see, here is 89.4 years in Woodley Park and 68.4 years in St. Elizabeth's. One way of looking at this and putting it into context is just a simple metro ride in Washington, D.C. And so if you were to start in Woodley Park on the red line and then transfer over to the green line and take that to Congress Heights, in a roughly 40-minute ride, you would lose 21 years of life expectancy in a city that's 62 square miles. And so much of that is connected to structural deprivation, structural racism, the social determinants of health, such as the inability to access quality health care and a quality education, as well as community context. So I'm glad to see many of my colleagues from Brady are here because I was interviewed by Brady a few years ago regarding what's underneath those red dots. To a lot of discussion and analysis using GIS, but not really humanizing what those dots actually mean. Those are people who represent those dots. Those are families that live underneath those dots, as well as neighborhoods where we see the concentration of gun violence in our communities. And so I won't belabor this point because I'm sure I'm preaching to the choir, but I just want to highlight that homicide is the leading cause of death of children in the United States. And firearm has persistently been the leading cause of death among young Black men for well over 3 decades. And in fact, 60% of all homicide victims are Black men, yet Black men only represent 7% of the US population. In 2022, there were 48,000 firearm-related deaths in the US, and 132 people every day die from a firearm-related injury. Why that statistic is so important is because roughly maybe 3 or 4 years ago, we had a 120 initiative, which stood for the 120 people that die every day from gun violence in the United States, was a consortium of universities and colleges here in the Washington, D.C. metro area that were brought together to address gun violence. And at that time, it was 120 people. That was maybe 3 or 4 years ago. It's now 132. As Alex mentioned, there are 100,000 people are injured by firearms each year. There are far more people that will suffer from non-fatal injury than will die from gun violence. And roughly 7 out of every 10 medically treated firearm injuries are from firearm-related assaults. But I think this last point is the most important because I've worked in the hospital violence intervention program world. The rate of re-injury is 65%. Which means on a trauma floor in any given day, if there are 10 people who are survivors of firearm injury, at least 6 out of those 10 people, this is their second, third, or even sometimes their 4th time being injured. Many would find that to be shocking, but that occurs every day in our trauma centers across this country. And nearly half of Black men who have survived firearm injury are hospitalized for a similar injury, at least 50% of them, and 20% are killed by a similar penetrative injury within a period of 5 years. And so when I'm working with young Black men who have been injured, I often hear their symptoms of traumatic stress. And what's quite interesting and profound is that when we look at the same literature with soldiers who have engaged in combat, we often find very similar symptoms of traumatic stress, whether they're anxiety, depression, nightmares, the inability to focus, and anger management issues. And in terms of children, there was a study done at the University of Pennsylvania which found that children who live within a 4 or 5 block radius of where gun violence has occurred and didn't necessarily have to witness it, but were more often likely to show up to a pediatric ED for a mental health related incident. On the left is my colleague and mentor, Dr. Carnell Cooper, is one of the pioneers of hospital violence intervention programs in the country at the University of Maryland Shock Trauma. And on the right is a handsome gentleman who was also the founding co-director of the Hospital Violence Intervention Program at the Capital Region Violence Intervention Program, which is here at the University of Maryland Capital Region Health. And my program was the first hospital violence intervention program to serve the DC metropolitan area. There are now 6 HVIPs in Washington, DC, and per capita, I believe we have the most HVIPs in the country. And so how can hospital violence intervention programs respond to gun violence? Well, as I mentioned, one of the ways that we do in Washington, D.C. with our 6 HVIPs is we provide psychosocial services in the form of cognitive behavioral therapy. We also provide legal assistance as well as employment assistance and connecting victims and families to other resources, and more specifically and importantly, also working with the caregivers of individuals who have been injured, because what we have found is that caregivers often suffer in silence and share similar symptoms of traumatic stress as the individuals that they're taking care of. And so this is what it looks like when I walk into a room. This is a young man that I've worked with. His name is Eric Bond. He was shot multiple times, and as you can see, he's still patched and stitched up. And fortunately, what our HVIPs are able to provide is a credible messenger who serves as a trusted and reliable person that often has a similar lived experience, who goes into those rooms to connect people who are typically distrustful of the healthcare and the criminal justice system, to connect them to resources. So what we have found in the literature among combat survivors is that soldiers are now being trained to deliver peer support to their colleagues. And using that model, my colleagues and I at the University of Maryland Aurora Center, which is a victims of crime clinic out of the University of Maryland School of Social Work, we also created a peer healing circle and a cognitive behavioral intervention where young men were provided the space to heal themselves. And so while we often provide therapists and conflict resolution specialists and violence intervention specialists to support young people who have been injured, we also think it's critically important that those who have the lived experience of being injured also participate, and we empower them to heal each other. Thank you. In a randomized controlled case study, my colleague Daniel Webster and I did a systematic review of HVIPs. We found among 100 participants in a randomized case control study that the intervention group, which was provided with services, had a 5% recidivism rate compared to the non-intervention group. And I just want to highlight this before I close. And the total cost of hospitalization for those who were in the intervention group was $138,000 compared to those who were in the non-intervention group was $736,000. So you can clearly see the cost savings. And this is what it cost in DC in terms of homicides and shootings. So you can imagine that's $783,000 for a shooting, and that includes healthcare and criminal justice costs. Just imagine the investment if we were able to make a minimal investment in preventing that cost, how much we could save in terms of lives and money. And so to close, this is the FASTER dashboard, which in Washington, D.C., we were fortunate to have funding from the CDC and to provide an analysis in real time of healthcare and how many people are coming into ERs for violent injury. And as you can see, the 912 visits was a drastic difference from the year before, where it was 1,189. And so I'll close with, we need more federal dollars to research what works for evaluating the effectiveness of HFIP programs. Are these programs cost effective? Well, at least in one of the cases, I've been able to show that, but I also want to highlight that the reviews on hospital violence intervention programs are mixed. And we definitely need more federal funding, and specifically in the research that we're doing to engage more in a qualitative analysis of the people who are participating in this program. And finally, the investments in these programs must be sustained because they save lives and they save money. Thank you.